Good morning to one and all who was present in the meeting, and also uh, good morning and good afternoon, good evening. I think there are plenty of people who are listening on this lecture online in YouTube and also uh, in Zoom. Thanks for attending this lecture series, and this is a lecture series which is happening on Saturdays 7 a.m. UK time on a regular basis. And those who want to get an update, either you can get an update in the Telegram or in the YouTube channel. So this is a free of charge. I don't charge anything. This is to help others, those who are interested in MRCS and FRCS examinations. And today's topic is going to be hepatocellular carcinoma. The next week, the plan is uh, anal diseases, including benign and malignant diseases. So let's go to the topic straight away. Okay, so hepatocellular carcinoma. So this is one of the rare form of carcinomas, and which has got a high rate of mortality all over the world. And still there are different researches going on in early diagnosis and good management of hepatocellular carcinoma. So regarding an introduction, the most common primary liver tumor is hepatocellular carcinoma. There are other tumors like fibrolamellar carcinoma, which mimic hepatocellular carcinoma, and also intrahepatic cholangiocarcinoma. So we dealt with intrahepatic cholangiocarcinoma last session, and that should be available in the YouTube. And the people, those who want to know about intrahepatic cholangiocarcinoma, can look into the videos. I don't provide any slides for anyone. You can have a quick watch of the lectures in YouTube videos. And this is regarding hepatocellular carcinoma. The most common liver tumor is hepatocellular carcinoma, and it is the sixth most common neoplasm in the world, and second cause of the death. It occurs most commonly in the males, and also it occurs in females as well. In females, the autoimmune hepatitis causing hepatocellular carcinoma is more common, and also the hepatocellular adenomas getting transferred or getting changed to hepatocellular carcinoma is more common in females. And the cause of death in hepatocellular carcinoma is not as such the tumor. The most important cause of death in hepatocellular carcinoma is hepatic failure, which constitutes 30% of the cause of the death, and the other one is GI bleeding, which accounts for 10% of the death in hepatocellular carcinoma. The advancement in liver transplant and prevention of hepatitis B virus and the treatment for hepatitis C virus decreases the incidence of hepatocellular carcinoma to some extent. In other ways, there are other causes as well which increases in the modern era. So the incidence of hepatocellular carcinoma varies in different parts of the world. Asia, in Mongolians, the incidence is more than 99 per 100,000 population. It's not 10,000, sorry, it's 100,000 population. And in Europe, it is less than 5 per 100,000 population. As I said, it happens more commonly in men, and there are plenty of risk factors like hepatitis B virus, hepatitis C virus, non-alcoholic fatty liver disease, alcohol abuse causing cirrhosis. And the most important thing is the incidence of the disease increases as the age increases, and it's more commonly seen in hepatitis C virus rather than hepatitis B virus. And causes of hepatocellular carcinoma is, in a nutshell, most important cause is cirrhosis. 80 to 90% of cirrhosis hepatocellular carcinoma occurs in cirrhosis, and the exclusively other causes are hepatitis B virus, C virus, and aflatoxins, alcohol, anabolic steroids. There are other non-sterotic causes like alpha-1 antitrypsin deficiency and other causes like hemochromatosis. So coming on to cirrhosis, as I said, it forms the major risk factor for hepatocellular carcinoma, and the most important risk factor in cirrhosis is chronic hepatitis. Any patient who has got long-term chronic hepatitis, which leads on to cirrhosis, has increased the risk of hepatocellular carcinoma. Primary biliary cirrhosis has less chances of hepatocellular carcinoma. However, it has got more chance of cholangiocarcinoma, and there's a chance of 10 to 20% of non-cirrhotic as well go for hepatocellular carcinoma, such as alpha-1 antitrypsin deficiency and hemochromatosis. So this is a picture which shows how the hepatocellular carcinoma happens, and this is the first picture is the normal liver, which goes for any cause in any inciting agent causing liver inflammation, causing hepatitis, and chronic hepatitis goes for fibrosis, and there is a regeneration of nodules in the liver, which leads on to chronic cirrhosis, and this chronic cirrhotic liver is more prone for hepatocellular carcinoma. The next comes is the hepatitis B virus infection. Though the hepatitis B virus infection is prevented by vaccines immediately after the birth, the vertical transmission is controlled, thereby decreasing the chances of chronic hepatitis due to chronic hepatitis due to HBV virus. However, there is something called as horizontal transmission, which is caused by needle prick and also a sexual transmission. Still, these things are not preventable, and there are though it is preventable by the vaccines, but it's not up to the mark. And the most important thing is chronic hepatitis because of hepatitis B virus is again an inciting or increasing risk factor for hepatocellular carcinoma. Immunization, however, prevents decreases the incidences, and the severity of the disease or the severity of the hepatitis B virus is more important, which is more prone for hepatocellular carcinoma. So the more the severe the disease, the more chances of hepatocellular carcinoma. Earlier, the chances of hepatitis B virus infection with a chronicity, more the chances of hepatocellular carcinoma. And there has been a study, there's a relationship between the hepatitis B core antigen with the hepatitis B surface antigen. So there is a tenfold increase of hepatocellular carcinoma in a patient who has got long-term existence of hepatitis B surface antigen, and there's a 60-fold increase in chances of hepatocellular carcinoma who has hepatitis B co-antigen or HBe antigen, and these are related to the hepatocellular carcinoma. The cells from the hepatocellular carcinoma has got all these viral DNA which has been found in hepatocellular carcinoma, and also the hazard risk increases to 6.1 when the copies of this DNA is increasing from 10 power 4 to 10 power 6. So in general, in a nutshell, there is a high chance of hepatocellular carcinoma with a HBe antigen found in a patient rather than HBs antigen, and both has been related to hepatocellular carcinoma. Likewise, hepatitis C virus, HCV virus infection, and the HCV virus infection, the chronicity of the HCV virus infection is more prone for hepatocellular carcinoma. The advantage of HCV virus is, as we have treatment protocols for HCV virus, we can prevent hepatocellular carcinoma by early treatment and perfect treatment of HCV virus. And it has been proved that any patient who has hepatitis C virus infection takes 30 years for the hepatocellular carcinoma to happen. So there is a big gap between the hepatitis C virus infection and hepatocellular carcinoma. Any patient who acquires HCV has to be cautious and vigilant in diagnosing, in early detection of hepatocellular carcinoma. There is an annual incidence of 2% after 30 years of age, and like in hepatitis B virus, there is no genomic association in HCV virus, and but higher the hepatitis C virus has got higher incidence of uh, hepatocellular carcinoma than HPV. Coming on to the HIV virus, and it has been proved that association of HIV along with hepatitis B and hepatitis C, the chances of hepatocellular carcinoma is 15 to 20 years earlier than the normal occurrence, and the deaths are 25% when the HCV and HPV is associated with HIV. So in general, there is a association of HIV, HPV, and HCV, and the hepatocellular carcinoma occurs earlier in these groups, and also the death is earlier in these groups. So the next one is non-alcoholic fatty liver disease, and non-alcoholic fatty liver disease is always associated with metabolic syndrome. The metabolic syndrome constitutes diabetes, hyperlipidemia, obesity. So it has been found that obesity and diabetes has got increased risk factor as an increased risk factor for hepatocellular carcinoma. And along with these things, if there is HBV and HCV infection, the chances are doubled, and there is a increased chances of hepatocellular carcinoma. So it has been found there is a 6 to 10% of metabolic syndrome are related to hepatocellular carcinoma. Next comes the alcohol intake, alcohol related to cirrhosis, alcohol-related decompensated liver disease or cirrhosis. In patients who take alcohol 50 to 70 grams or more per day are more prone for hepatocellular carcinoma than the other people. Hemochromatosis, it's an autosomal recessive disease. It has been found that there's a mutation in C282Y, which is related to hepatocellular carcinoma, and there is an association of iron overload in these sinusoidal areas. So I'll let you know about what's the significance of this iron overload and diagnosis in patients with hepatocellular carcinoma and hemochromatosis later in the slides. Uh, uh, in general, the primary biliary cirrhosis has got lower risk factor for hepatocellular carcinoma. However, compared to the general population, there is an increase in 18-folds of hepatocellular carcinoma. So the next other causes is autoimmune hepatitis, which is more common in females, as I said earlier, and it has got low risk of hepatocellular carcinoma. Aflatoxin B1, which is seen, which is produced by Aspergillus flavus fungi, these fungus are found in the old seaweeds. Most commonly, these aflatoxins causing hepatocellular carcinoma are found in Asian population. Other causes are like alpha-1 antitrypsin, phosphoryacutinia tarda, tyrosinemia. These are the glycogen storage or the metabolic disorders of the liver, which can lead on to hepatocellular carcinoma, like hypercitrullinemia, P53 gene mutation, and hepatic adenoma. I'll discuss about hepatic adenoma in the next few slides. So hepatic adenoma, as I said, hepatic adenoma, uh, the any female patient who's on oral contraceptives has a chance of hepatic adenoma, and size of the hepatic adenoma is less than 4 centimeters, there's a decreased risk of hepatocellular carcinoma. This hepatic adenoma can get converted to a hepatocellular carcinoma. It's a predisposer or risk factor of hepatocellular carcinoma. But however, the risk is less when it is less than 4 centimeters. The risk is more when it is more than 4 centimeters. Any lesion with hepatic adenoma with uh, more than 4 centimeters needs resection or excision and analysis. As I said, it is more common in females. However, it can happen in males as well. And as I said, it's mostly associated with intake of oral contraceptive pills. When hepatic adenoma occurs in males, the hepatocellular transformation is more earlier, or it's 10 times more common than if it happens in females. So the size of the lesion of hepatic adenoma when it happens in males has decreased, has been treated with less. Like for example, if the patient with hepatic adenoma has got hepatic adenoma happens in males, even if the lesion is 1 centimeter, it is considered for excision, as this has more potential to become a hepatocellular carcinoma. And also there's a mutation which has been found to be associated with hepatic adenoma is beta-catenin mutation in 10 to 15% of the patients. This is all other reasons associated with hepatocellular carcinoma are like type 1 glycogenosis and use of anabolic steroids, which I mentioned earlier, and or androgen treatments and Fanconi's disease. So coming on to the pathology, how this happens, how hepatocellular carcinoma progresses from normal hepatocytes to hepatocellular carcinoma. So initially there is a thing called as microcellular or macrocellular regeneration or regeneration, and then goes for dysplastic lesion which is less than 1 mm, and dysplastic nodules, it goes into dysplastic nodule. The hepatocytes, normal hepatocytes, becomes dysplastic lesion which is usually 1 mm, and dysplastic nodules which is usually 2 centimeters. So dysplastic nodules can be either low-grade dysplastic nodule or a high-grade dysplastic nodule. It is mentioned that it is termed as low-grade if it is 1 centimeter, and if it is if it is high-grade, it is 2 centimeter. The high-grade and low-grade, there is a less differentiation in high-grade tumors, and there's a well differentiation in the low-grade tumors, and then it changes. Then it changes to hepatocellular carcinoma. The hepatocellular carcinoma can be a solitary nodule or a small lesion in any of the lobes of the liver, or it can be multicentric on both the lobes and multiple areas. Sometimes we make it as dominant hepatocellular nodule with a satellite or micro nodules around it. So it's called as one dominant intrahepatic nodule with a satellite or metastatic nodule around it. So we otherwise call it as intrahepatic mets. So any dominant nodule with a small nodules around the dominant nodule, we call it as intrahepatic metastatic or metastasis of hepatocellular carcinoma. So when there is a poor differentiation, the prognosis is extremely poor. So this is what I was mentioning about any patient. As I said earlier, hepatocellular carcinoma happens in patients with cirrhosis. So when there is a cirrhosis, there is a fibrosis and regeneration of nodules. The regenerative nodules can become a dysplastic nodule. As I said, it can be low grade or it can be high grade. The low-grade dysplastic nodule is usually less than 1 centimeter, and the high-grade dysplastic nodule is usually more than 2 centimeters. So this dysplastic nodule, which shows signs of dysplasia, can become hepatocellular carcinoma because of any inciting agents, or it can happen due to the pre-existing cirrhosis as well. And this is called a small hepatocellular carcinoma with size the size of 2 centimeter, and large hepatic carcinoma, hepatocellular carcinoma with size of greater than 2 centimeter. So how are we going to grade the tumors? As we know, there is a low-grade dysplastic nodule, high-grade dysplastic nodule, and microdysplasia and hepatocellular carcinoma. And how are we going to grade the disease? And there are, it's called as an advanced grading of 1 to 4 grading. 1 is well differentiated, and 2 is moderately differentiated, 3 is poorly differentiated, and 4 is undifferentiated. It has been proven that there is something called a STIRT mutation, which happens in hepatocytes. In 60% of the patients, they could find this called as something called a STIRT mutation. And next is the markers. How are we going to use the markers to find hepatocellular carcinoma? The most common markers which are used are glypican-3, HSPR, heat shock protein 70, glutaminase synthetase, and CKD34 and CK7. And I will mention these things in the next few slides as well. So if there are 2 markers which are positive after a biopsy, it means hepatocellular carcinoma is proved. But how the thing is, if there is a poor differentiation, these markers can be absent. So when these markers, it's like a balance between the imaging finding and the biopsy finding. So well-differentiated tumor gives a positivity of these 2 markers, at least two markers out of these. And the next comes is the vascularization of the tumor, which is very important. The vascularization, any hepatocellular carcinoma gets its blood supply, most of the blood supply, from the hepatic arteries. In general, the liver, the hepatocytes are nourished or fed by portal veins. As the transition happens from degenerative nodules to the hepatocellular carcinoma, the vascularization changes. There's a new angiogenesis. It means the vascularization of the hepatic nodule or the tumor nodule is changed. It changes from portal vein to hepatic artery. So this is called as arterial neoangiogenesis, and it becomes the initial portal dominant hepatocytes goes for hepatic arterial dominance. So this is called as vascularization, and which is the key principle which helps us to diagnose hepatocellular carcinoma in the earliest part of the imaging. So you can see this is a very nice slide which can show the arterialization of a hepatic nodule, portal dominance, arterial dominance, and cellular nodularity, how the things changes, which is more prominent in which part of the disease. For example, there is a regenerative nodule, and as I said, there's a regenerative nodule, low-grade dysplastic nodule, high-grade dysplastic nodule, early hepatocellular carcinoma, and full-blown hepatocellular carcinoma. So as I said, there's an unpaired artery or neoangiogenesis which happens as the disease progresses, and the neoangiogenesis is completely formed when there is a hepatocellular carcinoma. So this neoangiogenesis gets its blood supply from the hepatic artery. So the regenerative nodule, which is more dependent on portal vein, becomes more dependent on arterial supply when it becomes a hepatocellular carcinoma. So the portal tracts in the nodule goes down as the disease progresses, and the cellular differentiation decreases as the disease progresses, and the nodularity increases as the disease progresses. So this is a very nice slide where we can say the portal tracts or the portal veins decreases and the arterial supply increases at this end. Also, I said you about fatty changes inside the tumor and also iron accumulation inside the tumor. So this hyperintensity or the iron accumulation can sometimes cause hyperintense nodule in the images, which is an artifact, like which is a tricky thing to diagnose hepatocellular carcinoma. So when there is an accumulation of fat inside the hepatocellular carcinoma, still there can be hypotense lesion at the arterial phase. So this is a like tricky when there's a fatty change inside the hepatocellular carcinoma. It has some kind of difficulty in diagnosing the hepatocellular carcinoma. The expression of OATP B1 B3 expression decreases as the tumor progresses. And the next thing is the fibrous capsule of hepatocellular carcinoma. Hepatocellular carcinoma has its own fibrous capsule, which sometimes gets invaded by the tumor cells. And this tumor cell invasion of fibrous capsule also is graded as minimal invasive, minimally microscopic invasion to macroscopic invasion. And also it is called as arterial spread. It means arterial spread in the sense it spreads inside the liver, and portal spread which is a poor prognosis. Any hepatocellular carcinoma which invades the portal vein forms a portal vein thrombosis, and this portal vein thrombosis gets its own blood supply. So the thrombus gets its arterial blood supply as well. So this is considered as a poor prognosis. Hepatocellular carcinoma with a portal vein invasion is a poor prognosis, not for transplantation or not for a curative, intention. And when there is a portal vein thrombosis, this patient gets the symptoms of portal vein thrombosis like ascites, splenomegaly, gastric varices, esophageal varices, and causes GI bleed and all other complications of ascites. And the next is the hepatic vein invasion. The worst form of prognosis is hepatic vein invasion. When the hepatic vein invasion happens, there is a thrombus formation in the hepatic vein, IVC, which can lead into a thrombus formation in right atrium, and that can be metastasis to lung. So this is the worst form of prognosis when the hepatic veins are involved. Usually, the hepatocellular carcinoma has got fibrous capsule invasion and then goes for a portal vein invasion, and then rarely there can be hepatic venous invasion. When there is hepatic venous invasion, it's the worst prognosis, and the inoperability or the curative intention is lost when there is a portal venous invasion. So when these patients with hepatocellular carcinoma goes for biliary obstruction, will there be any biliary invasion? Yes, there can be biliary invasion sometimes causing hemobilia, and the biliary invasion is rare compared to the hepatic artery, hepatic portal venous invasion, hepatic arterial invasion, and biliary invasion. Out of these three, biliary radical or biliary invasion is rare. When if it is involved, it can be either a small invasion which causes hemobilia, or it can be a huge mass in the a huge mass in the liver which causes obstruction of the biliary radicals, or a metastatic nodule in the porta hepatis which causes compression of the biliary radicals causing jaundice. So these are the causes of jaundice in hepatocellular carcinoma. As such, hepatocellular carcinoma highly unlikely to produce a biliary obstruction. So the causes of jaundice in hepatocellular carcinoma is not primarily because of hepatocellular carcinoma as such. It could be because of the tumor mass obstructing the biliary radicals or invasion of the tumor mass, rarely into the biliary radicals. And the metastasis, where can the hepatocellular carcinoma mets goes? As I said earlier, the worst prognosis is hepatic vein invasion, which can throw tumor cells into the lungs. So the hepatic vein invasion leads to the tumor cells reaching the right atrium and right heart system, leading to lung mets. The other areas of metastasis are pancreas, adrenal, bones, and these are the other areas of metastasis of hepatocellular carcinoma. So clinical presentation, when the patient presents with deranged liver functions, or when there is a hyperbilirubinemia with a mass, huge mass, and all these things are advanced stage, I can say the tumor is going beyond the curative intention. Usually, there are three ways of presentation of hepatocellular carcinoma. There could be incidental finding, where we do an ultrasound for some abdominal pain, mild abdominal pain. We find a hypodense lesion in the ultrasound, which is usually picked up by the ultrasound, and then we diagnose hepatocellular carcinoma. Or sometimes it can be malignancy symptoms like mass in the abdomen, fatigue, tiredness, poor appetite, vomiting, and these can be presented as malignancies, as hepatocellular carcinoma, and rarely deranged liver function where there's a huge mass comprising the biliary radicals, and there are few at times it can produce paraneoplastic symptoms like polyglobulinemia, hypercalcemia, and hypoglycemia. So the clinical symptoms, as I said, it can be right abdominal pain, right upper quadrant pain, and there can be distension of the abdomen causing ascites when there is a portal venous invasion, as I said, and there can be weight loss, and jaundice can be because of biliary radical obstructions, and fatigue, nausea and vomiting, chills and rigors, which are common for any malignancy. Diagnosis. Will the liver function test be helpful to diagnose hepatocellular carcinoma? No, the liver function test is not an indicator, or the deranged liver functions are not an absolute indication to diagnose hepatocellular carcinoma. Tumor markers, yes, tumor markers has good significance, especially alpha fetoprotein. So the normal alpha fetoprotein level is 0 to 20 nanogram per ml. So when the alpha fetoprotein is more than 400, or like when it is more than 400, we can diagnose it as a hepatocellular carcinoma when there is a hypodense lesion associated. When we do an ultrasound with our AFP, both the findings showing correlated findings, we can diagnose hepatocellular carcinoma. When there's a poor differentiation, the AFP increases more than even 10,000. So AFP is a good marker for diagnosing hepatocellular carcinoma. However, the other side of the AFP is the AFP can increase in non-seminal germinal tumors, hepatoid gastric tumors, and neuroendocrine tumors. So this is not as sensitive, more specific. I can say more specific. Cannot be a more specific marker for diagnosis of hepatocellular carcinoma. So can this AFP be used as a screening tool for hepatocellular carcinoma? Yeah, sometimes. When we screen any patient with AFP, if it is more than 20 nanogram per ml, there is a 40% chance, there's a 20% chance of missing hepatocellular carcinoma. If it is more than 100, AFP more than 100, there is a chance of like 40% chance of missing hepatocellular carcinoma. So it's a kind of tricky thing to screen patient with AFP. AFP is not a screening tool for diagnosing hepatocellular carcinoma. However, ultrasound can be used as a screening tool compared to AFP. The most important thing is other marker called as des gamma carboxylate prothrombin or DCP. This is used by the Japanese to find, and this is used by the Japanese. Combined with AFP, it has got very good sensitivity to diagnose hepatocellular carcinoma. And there is other tumor marker called as PIVCA or prothrombin. Not sure exactly what exactly it means. And PIVCA is prothrombin induced by vitamin K absence. Prothrombin induced by vitamin K absence. These two, when combined with AFP, has got high sensitivity in diagnosing the hepatocellular carcinoma. So as I said, these combines to have a good diagnosis of hepatocellular carcinoma. These things are also tumor markers like AFP. So as I said, vascularization, imaging, when we come to imaging, the vascularization has got a very good influence on imaging. Vascularization, as I said, vascularization is nothing but the portal dominant hepatocytes becomes arterial dominant hepatocytes when it becomes a hepatocellular carcinoma. So the imaging looks at 3 phases or 4 phases: arterial phase, portal venous phase, and there's an equilibrium phase. So we call it as arterial phase and washout phase. And what are the images which are used? Ultrasound. And now they come across something called as ultrasound under contrast enhancement. So instead of using contrast for a CT scan, we use a contrast for an ultrasound and diagnose hepatocellular carcinoma, and other imaging are CT and MRI. As a screening tool, as I said you already, screening tool, ultrasound has got a good screening capability. However, there are there are pitfalls like user dependence, the sonographer's interest. The most important thing is anything which is around 3 to 5 centimeter can be easily picked up by ultrasound, and there's a 90% chance of picking it up. And if it is around 1 centimeter, 60 to 80 centimeter of 80% of hepatocellular can be picked up if it is around 1 centimeter size. The most important problem are the H is we cannot differentiate a regenerating nodule and a dysplastic nodule, and this difficulty is overcome by the contrast enhancement during ultrasonogram. And also the next one is the superficial nodes, and there are hepatocellular carcinoma which happens in the left lateral segments or left lobe of the liver, and there are few segments which is superficial, like segment 7 and 8. When the patient is obese. So these are the difficulties in screening with ultrasound. In a nutshell, any patient, the contraindication are we can miss a diagnosis of hepatocellular carcinoma under ultrasound if the cancer or if the hepatocellular carcinoma happens or exists in a superficial lobes like segment 7 and 8, or in left lateral segments, or when the tumor is less than 1 centimeter, in a patient who's obese, and all these things can be missed when we screen a patient with ultrasound for a hepatocellular carcinoma. CT scan, it's a more accurate form. We can pick up any superficial lesion as well. And as I said, the arterial phase enhances the tumor, and the portal phase goes for washout. So as the tumor is supplied by the artery, there is a good enhancement of the lesion during the arterial phase, and in the portal phase, the washout happens. So it becomes hypointense. So hyperdense tumor the hitch here is, as I said, when there is a fatty infiltration or iron overload, there is a difficulty in diagnosing the tumor when there with this arterial phase and portal phase. The most important thing is the fibrous capsule invasion, which can be picked up by the portal phase easily. So next comes the MRI. MRI is more accurate when it is more than 2 centimeter. As I said, you again the same principle applies here as well. When it is T1, it becomes hypointense. T2 becomes hyperintense. Lesion can be seen in MRI. Rarely, in 16% of the patients, there can be both T1 and T2 can be hypointense. There's something called as gadolinium EOBDTPA specific, liver specific, or cover cell specific dye, which is used in MRI to diagnose hepatocellular carcinoma. This is coming up with a good sensitivity and specificity if we use GDEOB DTPA contrast enhanced liver specific MRI, which helps in diagnosing the hepatocellular carcinoma. As I said earlier, there is something called as contrast enhanced ultrasound as well, and they use sinusoid ultrasound contrast. These are taken up. This contrast is taken up by the cover cells or vitamin A. Cover cells are storage cells. Supporting cells which are present in liver. So these cells takes up sinusoid dye and retains it for 10 to 20 minutes. So these things helps in diagnosing the hepatocellular carcinoma. Also, they are regarding angiography, it's not that useful. Coming on to the PET, is the PET useful for diagnosing hepatocellular carcinoma? As the hepatocytes and the normal hepatocytes and the hepatocellular carcinoma uses the glucose in the same way, the FDG PET is not usually routinely used, and it is not of use in hepatocellular carcinoma. However, the lipid metabolism is helpful to some extent. However, PET scan is not routinely used to diagnose hepatocellular carcinoma. If at all, if it is used, we use 18F fluorocholine lipoidal. So this dye, this thing is used in relation with the lipid metabolism, and this helps in diagnosing the hepatocellular carcinoma if we diagnose using PET. Compared to CT and MRI, PET is not going to be useful in diagnosing hepatocellular carcinoma, as it also is cost effectiveness. The next comes is the I'll explain you about this centimeter lesion, how to assess the liver nodules regarding hepatocellular carcinomas in the next day. So this is MRI features of regenerative nodule, dysplastic nodule, and hepatocellular carcinoma. As I said, there is no arterial enhancement in regenerative nodule and dysplastic nodule. However, there is a good arterial enhancement in hepatocellular carcinoma, and the portal venous enhancement is not there, and there is a washout. The term is called as washout in hepatocellular carcinoma. Interstitial enhancement is also less in hepatocellular carcinoma. The T1 and T2 images is as is mentioned here. You can just have a look at it. So this is MRI enhancement. This slide gives you the MRI enhancement of hepatocellular carcinoma. So diagnosis, how are we going to diagnose? Now we have all images, biopsy report, tumor markers, imaging, ultrasound, CT, MRI, PET. So what are we going to do for different liver nodules of different sizes? And there are two entities here in hepatocellular carcinoma. Any patient who has cirrhosis and a normal liver. Patients with cirrhosis can have hepatocellular carcinoma. Patients well, normal liver can have hepatocellular carcinoma. Any patient with a cirrhosis with hepatocellular carcinoma of size, any ultrasound which shows suspicious nodule of 1 centimeter, we have to deal it in different way. And non-cirrhosis 1 centimeter needs biopsy. As I said, these stainings are used CD34, CK7, GPC3, heat-shock protein like glypican 3, heat-shock protein 17, and glutamine synthetase staining. So all these things are used if there is a biopsy which is done for a non-cirrhotic 1 centimeter lesion. Let's give you a clear slide, the flow chart, how to assess a liver nodule for a hepatocellular carcinoma in the last future. This is the slide which I was saying about. So any nodule on ultrasound, if it is less than 1 centimeter, it is less likely to be hepatocellular carcinoma. The doubling time of hepatocellular carcinoma is 200 days. So I repeat, the doubling time is 200 days. So any hepatocellular carcinoma of less than or any nodule less than 1 centimeter, we can repeat the ultrasound 3 to 6 months. Here it is mentioned as 4 months. We can repeat it for in 3 to 6 months, and if there is a character of growing or changing character, then investigate with CT or MRI depending on the size of the tumor. And if it is stable for 2 years, so repeat ultrasound every 6 months, every 3 to 6 months, and then if there is an increase in size, investigate as per the size. And if it is stable for 2 years, then there is a routine surveillance of like 1 to 2 years surveillance on a routine basis. If the nodule is 1 to 2 centimeter, do a 4-phase or triphasic CT, check for arterial enhancement, venous enhancement, and venous washout or arterial enhancement, and look into it. If it shows hepatocellular carcinoma, then go ahead and do and treat as per the need, as per the size of the hepatocellular carcinoma. And if it is less than, if it is 1 to 2 centimeter and there is no arterial enhancement or washout, then it is better to biopsy and look for the stainings, like as I said you earlier, CD 34-7 and GPC, all the stains, and think about hepatocellular carcinoma. If it is more than 2 centimeter, there's no doubt straight away we can do a CT or MRI, contrast as MRI. And if there is one positive technique, or if there is one arterial enhancement or venous washout, any one is positive, then go for uh, uh, diagnosis of hepatocellular carcinoma. If if nothing is inconclusive, then again biopsy and then deal accordingly. Staging, there are different staging, AJCC staging and liver cancer study group of Japan. And all these things are based on the size of the tumor, which is tumor less than 2 centimeter, more than 2 centimeter, and vascular invasion, fibrous invasion, portal venous invasion, arterial invasion. All these things are put together to diagnose the hepatocellular carcinoma with the complications. And the prognosis, there are different prognostic models. Kretsch, CLIP, QP model. Most commonly used is CLIP and also BCLC, or Barcelona liver group prognosis. So in general, the prognosis is good if the bilirubin is less than 50 and Child-Pugh A without portal invasion, without any meds, the prognosis is good. When there is a portal venous thrombosis or portal venous involvement, the prognosis decreases. And if the AFP is more than 700, the prognosis decreases. Child-Pugh B and C, again, the prognosis goes down. These are like early forms of hepatocellular carcinoma. There is a curative intent, and there is the curative intent decreases for any patients who has got Child-Pugh B and C. So the next slide is treatment. So there are different treatment options, and the best treatment option is liver transplant and liver transplant. And but the criteria are very strong for liver transplant patient. When the patient comes with hepatocellular carcinoma, the criteria is very strong for liver transplant, and there is a chance of liver resection, and also it also depends on the type of the liver. Is the liver is a normal liver or a cirrhotic liver? And the 5-year survival is really 50%. Lymphadenectomy is, if it is involved, that many patients, around 15 patients, 15% of the patient who undergoes surgery for hepatocellular carcinoma needs lymphadenectomy. Usually the porta hepatis is involved. And as I said, the treatment option mainly depends on cirrhotic liver and non-cirrhotic or normal liver. In a cirrhotic liver, if you are planning for a liver resection, it has to be analyzed properly. The remnant liver or the residual liver, the functional residual liver, the residual liver volume must be 40% if it is a cirrhotic liver. And this residual volume um, can be achieved pre-operatively by all these liver imaging and the apps which we get in the radiology. We can get a approximate liver image, and sometimes the portal venous embolization of the liver of portal venous embolization can help. For example, if the patient is going for a right hepatectomy in a cirrhotic liver with the left uh, uh, with a normal left lobe of the liver, and the hepatocellular carcinoma involves the right lobe of the liver, 4 to 6 weeks prior to the procedure, we can embolize the portal vein on the right side so that the right lobe gets less of blood supply and there's an increased flow to the left lobe. The volume of the left lobe increases, which has got a, after 6 weeks, there is a chance of good functional or residual liver volume to sustain the patient. And this happens, the portal venous embolization helps in patients who's planned for liver resection and for hepatocellular carcinoma. It also helps in other malignancies as well. However, if it is a normal liver, the functional or the residual lung volume, if it is 20% is sufficient, it is sufficient for sufficient with 20% residual volume. And ICG is iodochromo stain. In Japan, this dye is injected before the procedure, and they find how much of ICG is retained in the liver or in the blood. If it is 10% retaining 10% is normal. If it is more than 22%, they avoid liver resection. If it is 14%, they go for uh, a small volume liver resection. It is no more. It's not used widely apart from Japan. So regarding margin of resection, when we plan for a liver resection, so as I said, hepatocellular carcinoma can be treated by liver resection or liver transplant. The standard is, the best is liver transplant. When it is liver resection, when we plan for liver resection, the margin has to be minimum of greater than 2 centimeter. Anatomic liver resection is better. So in the sense, like it should be left lateral sectionectomy or right lateral sectionectomy or right lobe or whatever. It has to be minimum of 2 centimeter margin. There is a chance of recurrence. The recurrence can be 40% in first year, 60% in third year, and 80% in fifth year. And also, the recurrence can be either treated by repeat resection or a liver transplant, depending on the situation. This has to be again reassessed. The recurrence has to be again reassessed and then decided about the management. Regarding adjuvant and neoadjuvant therapy, sorafenib is an anti-angiogenesis. Again, the angiogenesis plays here. Angiogenesis is the key in hepatocellular carcinoma. So sorafenib is an anti-angiogenetic monoclonal antibody which inhibits angiogenesis, decreases the recurrence and decreases the increases the prognosis of the disease. And so these are the criteria to decide about which patient needs transplant and which patient needs a resection. The Millen's criteria is usually used in all across Europe. So Millen's criteria is nothing but one lesion less than 5 centimeter and 3 lesions, which is in total less than 3 centimeter. So if these things are there, we can plan for liver resection. If this Millen criteria is exceeded, then we can go for a transplant. There are other criteria as well, like University College of San Francisco criteria, where the lesion size is more than less than 6.5 centimeter. Different people use different criteria. Stick on to one criteria, which is more. Europe follows Milan criteria. So liver transplant for hepatocellular carcinomas. What are the strict criteria? And what are the advantage of liver transplant over liver resection, and what are the criteria for liver transplant? So liver transplant criteria, if it is confined to the liver and there is no hepatic disease or including lymph node, and without vascular invasion, especially portal vein, hepatic vein, or arterial invasion, and there is a limited tumor burden. So these are the three most important criteria uh, to subject any patient with hepatocellular carcinoma for a liver transplant. And liver transplant is also we consider Milan's criteria as well for the liver transplant. Living donor liver transplant helps in avoiding the waiting list. If there is a patient who has liver available for a transplant for a hepatocellular carcinoma, yes, it helps. There are other methods to tide over the situation, like tear and TACE, where the patient can be subjected to tear and TACE methods of tumor ablation during the waiting period. What is TACE? Transarterial chemoembolization. Again, the vascularization or the arterialization of the tumor helps in this kind of treatment. This is also used as a palliative treatment for hepatocellular carcinoma. Any patient who is not of curative intention is going to be under TACE or TAR procedure. TACE is the most important principle is the artery which is feeding the hepatocellular carcinoma or the nodule is selected, highly selective artery is embolized with a chemotherapeutic agent. The most commonly used chemotherapeutic agent is doxorubicin, and there are other chemotherapeutic agents as well, like sometimes lipoidal can be iodized oil or lipoidal can be used, but the chemotherapeutic agent which is used is doxorubicin. And post-embolization, there are plenty of other complications like gallbladder necrosis, gangrene, duodenal injury, abscess formation, and these are the side effects of any chemoembolization or radioembolization. The patient can be subjected for sorafenib, which I said your anti-angiogenic, after the procedure or after the if there is a palliative intention of the treatment. Again, radiofrequency ablation, TAR or transarterial radiofrequency ablation, either it can be the radioactive substance which is used is yttrium-19, and the side effects are the same like that of the TACE. And all these things, TAR and TACE, are used for any patient who is in the waiting list and who is waiting for a transplant or for a resection. and especially for a transplant, not for a resection, for a transplant, or it can be used as a palliative measure where the patient is not fit for transplant or who's not fitting into the Milan's criteria. So this is how we treat the hepatocellular carcinoma. Any patient who has got stage 0 with a child view A, single nodule, nodule less than 3 centimeter, portal pressure or bilirubin of very less than 30 millimole, 30 milligram, sorry, microgram per deciliter. And when these patients with usually stage 0, we plan for resection or liver transplant. And if there is associated disease, plan for transplant rather than resection. For example, if a patient has got cirrhosis or hepatitis B, chronic hepatitis, with a hepatocellular carcinoma, plan for a liver transplant rather than a resection. A normal liver with hepatocellular carcinoma with a Millian criteria, which satisfies Millian criteria, can go for resection. And any patient who goes for a stage A, stage more than stage 0, is planned for radiofrequency ablation, TAS, and sorafenib. And any patient who has got advanced, definitely no, even there is a portal vein invasion, there's no role for even tear or TAS, go for sorafenib and best supportive care if it is extremely metastatic. So the other variant of the hepatocellular carcinoma is fibrolamellar carcinoma. It's a variant, as I said, 90% of the primary carcinoma of liver is hepatocellular carcinoma. The next other one is the fibrolamellar carcinoma, which is around 10%. The significance of this carcinoma occurs early in the life, 30 to 35 years of age, and has got a very good prognosis. It presents as a large tumor when it presents. And there's a 5-year survival of 50 to 78%. So how it differs from the hepatocellular carcinoma, the most important thing is there is a central vascular hyperinnervation, which signifies there is a central scarring of this type of carcinoma. The AFP is raised in only 10% of the people, and there's a most common lymph node invasion in more than 60% of the tumor. So it's a variant of hepatocellular carcinoma where there is a lymph node involvement, central scarring, and occurs early in the life. And the 5-year survival is around 50 to 75%. Thank you. And this is about the hepatocellular carcinoma. The next session will be on benign and malignant anal diseases on 31st of July. And I can open up. So if there is anyone who wants to ask anything, they can ask. There was a chat question. Chat, hi sir. How do we differentiate adenoma, follicular hepatocellular on CT scan? As I said, the hepatocellular carcinoma, this is as clear. It's hepatocellular carcinoma, uh, arterial hyperintensity. You will have a intense image in the scan, and there will be portal venous washout. So that's more important to diagnose hepatocellular carcinoma. And adenoma, again, the size is difference in size. The hepatocytes, even the CT. So this is all these things are arterial phase enhancement and portal venous washout. Any questions from anyone? can unmute if needed. In the YouTube and also other media platforms. I will share it in Facebook as well. Thanks for attending. And the next will be in the on 7 a.m. 31st of July. Thank you. Anyone has got any? So there's a question asked by Mr. Mohammed Arif. CT volumetry in hepatocellular carcinoma, it's usually in Europe, I don't think they do it as a routine, especially when there is a patient with cirrhosis. We have to be cautious about the liver volume after a resection if you're planning for resection. Any patient with cirrhosis, the best treatment is transplant rather than going for a resection. And when we plan for a resection, then yes, volumetry is very important depending upon the tumor size. And if you are planning for a less amount of, like, for example, if the residual liver volume is less than 40%, if we think that it's going to be just less than 40% and we are going to kill the patient on table, because 40% minimum is important. And there is something called as there's other way the patient liver functions are assessed prior to the procedure, and make sure the volumetry is done if it is a cirrhotic patient. If not, there's a less chance of doing a volumetry in a normal liver who's planned for resection. If there is a transplant for the hepatocellular carcinoma, there's no reason to do a liver volumetry. I hope that this thing will. Thanks for attending. The next class will be again on 31st of July, Saturday. So I am trying to do these classes on weekly basis to my time availability, 7 a.m. UK time on all Saturdays. And today it was a bit delayed. The next will be the next week, next Saturday, 7 a.m. And the topic will be anal diseases. It can include all fistula, fissure, anal carcinoma, and all the bottoms like hemorrhoids and everything. It will be helpful for both MRCS and FRCS candidates, those who are appearing for both MRCS and FRCS candidates. Yeah, I'll try to go it on some other day. Next, the next class. Anyone has any preference, you can post it so that I'll try to find the topics to go. Thank you all. Thanks for attending, and this is available in YouTube Live as well. And as offline as well. Thank you. Thanks for attending. And to end the session, thanks for attending.